Okay, well, we'll go ahead and get started. Thank you all for being with us today and welcome to our webinar. We are very excited to share with you our disease models that can help you identify novel therapeutics targeting cytokines and or their cognate receptors. But before we get started, I would like to introduce myself and our expert panelists. I am Rebecca Soto and I will be the moderator for today's webinar. I have a PhD in biological and biomedical sciences, and my primary role at Biocytogen is to develop scientific content. I'm joined today by our speaker, Dr. Jenna Frame. Jenna is a senior manager of science communication and marketing and has over 15 years of experience working with genetically modified animal models in the field of developmental hematopoiesis. I'm also happy to be joined by two expert panelists, Dr. Ravneet Chabra and Dr. Luke Yu. Ravneet obtained her PhD in cell and molecular biology and has a master's degree in biochemistry. She has 5 years of experience working with oncology models, and at Biocytogen, she works as a business development manager, helping scientists meet their research needs and aiding in successful project collaborations. And lastly, Luke serves as our Deputy General Manager and Global Head of Preclinical Pharmacology here at Biocytogen. Luke has held several leadership positions, specifically in drug discovery and development at both the preclinical and clinical stages. So with that, welcome to our speaker and our panelists and all of you. We will be taking questions at the end, so please stay tuned. Now I would like to invite Jenna to begin her presentation.
Excellent. Thank you so much, Rebecca, for that introduction. And thank you all for tuning into today's webinar. So as Rebecca mentioned, today I'll be introducing some of our inflammatory disease and injury models of the joint, lung, and kidney that can help you to discover new therapeutic mechanisms and strategies for treating these diseases in humans. So before we jump in, I first want to highlight the work that our team has put in at Biocytogen this year to develop a range of disease models for inflammatory diseases, metabolic diseases, as well as other diseases, as you can see in this list here. And we are continually working on developing new models, which you can see are listed here in the orange text. So today's presentation will kick off with an overview of our joint models, including models of RA, osteoporosis, and osteoarthritis. We'll then discuss some lung injury models, including acute lung injury and pulmonary fibrosis. We will then follow up with data from our lupus model and a model of chronic kidney disease. So the first is rheumatoid arthritis models. So just a brief introduction. Rheumatoid arthritis is among the most common autoimmune diseases, and its clinical symptoms mainly include generalized joint swelling, pain, and mobility issues. Severe cases of RA lead to disability as evidenced by hyperplastic synovitis, cartilage injury, and bone structure loss. First-line treatments include steroids or methotrexate, and for severe cases, biologics that block cytokine-induced inflammation. So pathogenesis of RA typically involves infiltration of inflammatory cells and autoreactive CD4 T cells into the joint tissue, resulting in pro-inflammatory cytokine production, complement activity, and autoantibody deposits. The cytokines induce production of MMP and ring ligand production by fibroblasts that activates osteoclasts and destroys tissue, resulting in joint destruction and pannus formation. So one method for inducing rheumatoid arthritis-like symptoms in mice is by injecting antibodies that recognize collagen directly. So in this model called collagen antibody-induced arthritis, after the antibodies are injected, and then after 3 days, there's a stimulation with LPS injection, followed by continuous monitoring of the animals until the experimental endpoint, which in this case is 20 days. This induction method is gaining popularity in the field due to the short time window and high incidence rate in the mice. So as you can see, the mice are scored for disease incidence by the presence of joint redness and swelling. the number of joints affected, and the severity of the swelling. So when this model is induced in C57 black 6 mice, you can see that the clinical score, which again is as reflected by the joint swelling indicated, the clinical score increases and maxes out over a period of about 10 days, during which the body weight drops and slowly recovers compared to the control group. And as mentioned, the incidence in C57 black 6 mice is at 100%. Looking at histology of the joints of these mice injected with the collagen antibodies indicates extensive inflammatory infiltration into the joint spaces, which led to a quantifiable difference when the mice were scored based on the pathologic score. So the next model is collagen-induced arthritis, or CIA, which is another common experimental rheumatoid arthritis model. Now, this model is induced by immunization with type 2 collagen. And this is the major constituent protein of articular cartilage. So animal models immunized with COL2 develop autoimmune polyarthritis, which shares several clinical and histologic features with rheumatoid arthritis. So in this set of studies, we again used mice on the C57 black 6 background, but other strains such as DBA can be used. The immunization is given on day 0 with a challenge on day 21. And test articles are typically provided around the onset of disease symptoms and can be given every 3 to 4 days typically. Again, we use the same clinical score, as I mentioned earlier, to score the disease severity in these mice. So in this first proof of concept study, wild type C57 black 6 mice immunized with collagen 2 gradually worsened clinically with a disease score that increases in severity after the second immunization. These symptoms are observed at about a 70% incidence rate in the C57 black 6 strain. Examination of joint pathology in these mice indicates, again, inflammatory cell infiltration, narrowing of the joint spaces, as well as destruction of normal tissue architecture, indicating that the disease was successfully established. In this next case study, we tested the efficacy of methotrexate, which, as I mentioned, is a first-line therapy for this disease. So in this experiment, the treatment was started on day 22 post-immunization and given every 2 days. So as shown in B here, the severity of the disease score was significantly reduced with administration of the drug, as shown by the green lines. And incidence of symptoms was overall reduced with drug treatment. In this experiment, the methotrexate group experienced less weight loss when compared to the COL2 immunized group alone. Together, these data indicate that the model was successfully established and that methotrexate effectively reduces arthritis-related disease symptoms. So the overall assessment of ankle joint pathology in these mice indicates that mice treated with methotrexate had less dramatic histologic changes. So while COL2 treatment alone caused significant disruption to the joint architecture, those immunized mice treated with methotrexate still had some inflammatory cell infiltration and slight edema. But overall, these data suggest that the disease severity could be partially alleviated with methotrexate administration. In the next RA study, we aim to test the efficacy of anti-human IL-6 in this model. So before I introduce that study, I'd like to first introduce our humanized IL-6 and IL-6 receptor model. So this model expresses mouse IL-6 in place of human IL-6 in place of the murine counterpart, as shown by Eliza. Likewise, this model expresses human IL-6 receptor on the surface of TCR beta positive T cells, as shown here. So in this study, the anti-human IL-6 antibody, sirukumab, was given at 2 separate doses after induction of CIA. So as you can see in the graph here on the right, the disease was successfully induced in immunized mice, as shown by the red line. And the severity was also reflected by reduced body weight of the animals compared to the PBS controls shown in black. However, the disease score was significantly improved with the higher dose of the antibody therapy, as shown by the blue line. Together, these results indicate that IL-6 blockade was able to improve arthritis-related clinical scores in a dose-dependent manner. Histologic examination of the joints of these mice by H&E staining indicates that, as previously shown, the mice immunized for Col2 caused significant damage to the bone structure and loss of periarticular spaces when compared to control mice on the left. However, immunized mice that received high doses of sirukumab had less severe pathology, exhibiting partial pannus formation but overall reduced disease scores, shown here by the blue bars. Again, these results indicate that blockade of human IL-6 was able to partially improve arthritis-related disease in humanized mice. In this next study, we used a different strain of mice humanized for the TNF-alpha signaling pathway. These mice were induced to develop CIA as previously described, and when the clinical score was greater or equal to 1, the mice were randomized and treated with anti-TNF antibody on days 0, 3, and 6 post-grouping. The clinical score of these mice, which again is related to the joint swelling, is significantly improved with the higher dose of the drug, as shown by the red lines, when compared to collagen 2 alone, which is shown in green. Histologic examination of the joints indicate that the high dose of the drug was able to reduce severity of inflammatory cell infiltration and other phenotypes when compared to Col2 alone, resulting in an overall improvement of the pathology score shown here in the bar graph. So the next joint-related model is a model of osteoporosis. So osteoporosis is an age-related disease manifested by loss of bone density with postmenopausal women at higher risk of developing the disease. The disease can be modeled by removing the ovaries from female mice, as this mimics the bone loss triggered by estrogen deficiency seen in older women. The mice are then monitored for weight and other bone measurements. So as you can see here on the right side, overectomized mice, here abbreviated as OVX, do gain more body weight when compared to their sham counterparts, as has been previously reported. As expected, the uterus weight is also significantly decreased due to the lack of ovaries in the disease model group. To measure the bone density and other characteristics in the osteoporosis model, CT scanning can be employed, as shown by the example here on the left-hand side. So several parameters can be quantified by these images, including bone volume divided by total volume, trabecular number, thickness, and spacing, as well as cortical bone volume, thickness, and spacing. So from the graphs in this particular experiment, we can see that there is a decrease in overall bone volume, as well as a reduction in the trabecular bone number, as well as increased spacing, but no difference in trabecular thickness. On the bottom, there is a marked decrease in cortical bone volume and thickness. And in this particular experiment, there was no significant changes in the structure model index or SMI or connectivity of the trabecular structures, although there are some trends present. So altogether, the significant reduction in bone volume is indicative of osteoporosis-like disease in these mice. Similarly, this study can also be performed in rats. So in this example, Sprague-Dawley rats were examined 8 weeks post-ovarectomy. And serum levels of alkaline phosphatase were elevated from 2 weeks post-surgery, indicative of increased bone loss. Overall measures of bone mineral density from micro-CT scanning over time shows a massive decrease in the overectomized rats compared to sham counterparts, indicating that the disease has successfully been established. Further micro-CT parameters measured in these rats are indicative of bone structure changes, somewhat similar to what was observed in the murine model, including a significantly decreased bone volume over total volume in the overectomized mice, which was also associated in a reduction in the overall number of trabeculae and a large increase in trabecular spacing. So in these rats, SMI was significantly increased, which can also be an indication of increased fragility. In addition, there's also a decrease in trabecular bone mineral density, or BMD, and trabecular tissue mineral density in the experimental group. So altogether, these rats have osteoporosis-like phenotypes. The final joint injury model is that of osteoarthritis, which is essentially a wear and tear disease of the joint that can result in loss of articular cartilage, such that bones can no longer glide against one another and causing pain and abnormal joint architecture, including bone spurs, which are commonly called osteophytes. ACL transection, or ACLT, is a commonly used injury model to induce inflammation and accelerate the progression of OA-like disease in animal models. So in this model, C57 black 6 male mice were subjected to ACL transection to induce disease. And after 8 weeks post-surgery, animals were assessed for disease parameters using histologic methods and micro-CT. So histologic examination of the femurs is shown here, with a reduction in the safranin O positive articular cartilage in these mice compared to the sham counterparts. Quantitation of the histopathology using the Osteoarthritis Research Society International, or ORSI, classification system, which you can see is denoted in this chart here, suggests that these mice do have OA-like disease. Finally, micro-CT scanning of these mice indicates a significant presence of osteophytes, which again are these tiny bone spurs, as well as a reduction in thickness, indicating that the disease has successfully been established. So the next set of diseases I will introduce today are lung diseases. So acute lung injury can be triggered by inhalation of various allergens, microorganisms, plants, or chemicals to induce inflammation. And this can be modeled by exposure of mice to alternaria or papain, which disrupts the airway epithelium, triggering a rapid eosinophilic inflammation. Pulmonary fibrosis is a lung disease which can be triggered by toxins like asbestos, coal dust, or silica. And fibrosis really involves scarring and thickening of the lung tissue, which makes normal breathing difficult. And the experimental model of pulmonary fibrosis commonly used is exposure of mice to bleomycin, as it causes inflammation via cellular damage. So in this first study, C57 black 6 mice were subjected to intranasal administration of papain at 3 different doses, which is a cysteine protease for 3 days. After 7 days, immune cells in the bronchoalveolar lavage fluid, or BALF, were assessed. And this revealed a significant influx of CD45 positive cells, as well as numbers of eosinophils in the BALF of these mice. The percentage of eosinophils in the CD45 population also appeared to increase in a dose-responsive manner. So pathological changes in these mice were demonstrated by vascular and peribronchial mixed inflammatory cell infiltration with the papain treatment, as well as excess mucus accumulation in some bronchi, as visualized by the PAS staining, which stains for carbohydrates such as those found in mucus. And then although not shown here, cytokine analyses can also be performed in these mice. And here's just the scoring of inflammatory cell infiltration and bronchial mucus from the histologic staining. So in this next study, intranasal administration of Alternaria, which is a fungus, or PBS, was given to mice over a period of 4 days. So although this treatment did not change the overall number of CD45 cells infiltrating into the lung, this model increases the number and percentage of eosinophils in the BALF, as in the PEPI model, suggesting that inflammation has been successfully established. Moving on to the pulmonary fibrosis model, which is accomplished via intratracheal administration of bleomycin. So as shown, mice were injected with bleomycin on day 0. And treated mice tend to lose some body weight and have a slight reduction in survival. Histologic assessments indicate significant disruption of the normal lung architecture with bleomycin treatment, as well as increased deposition of collagen shown by serous red staining. Hydroxyproline measurements are also significantly increased, which is another measure of fibrosis. In this example, humanized mice for CCN2, which is also known as CTGF or connective tissue growth factor, were treated with bleomycin to induce disease, as shown here on the timetable, and then also treated with anti-human CTF antibody pamrevlumab to test whether the treatment can alleviate fibrotic accumulation. So assessments of body weight and survival of bleomycin treated mice, also given the antibody, demonstrates an improved body weight compared to the vehicle control shown in red. In addition, there is no reduction in survival of the antibody treated mice compared to the control mice, suggesting that the drug effectively reduces mortality. Upon histologic examination of these mice, disruption of the lung architecture with bleomycin treatment is significantly improved with pamrevlumab treatment. Similarly, hydroxyproline measurements, which is again serving as a method for fibrosis quantitation, is also reduced in the antibody treated group compared to bleomycin alone. So together, these data indicate that the fibrosis model was successfully established and that other test articles could similarly be evaluated. So before we wrap up, I'll introduce 2 more models focused on kidney disease. The first being a model of SLE, which is an autoimmune condition characterized by autoantibodies that cause tissue damage in several organs, including the kidney. So SLE is modeled by administration of the chemical pristane, which is given as a single IP dose to Valp C mice. After 8 months, proteinuria in the urine and mouse anti-double-stranded DNA IgG in the serum are found to be elevated after treatment, indicating that SLE-like disease is induced in the mice. Histologic analysis of the kidneys of this SLE model by H&E staining, PAS staining, and Masson staining showed glomerular stromal cell hyperplasia, glomerulosclerosis, and fibrosis in the pristine treated group. Again, indicative of kidney disease in these mice that could be subjected to your promising test articles. So finally, the last model that I will introduce is a model of chronic kidney disease. So in this case, the 5-6 nephrectomy model is employed, and this involves removal of one kidney, followed by excision of 2/3 of the other kidney 1 week later. And the remaining tissue that's left experiences high filtration and pressure, leading to glomerular sclerosis and fibrosis. So in this particular example, C57 Black 6 mice were subjected to the 5/6 nephrectomy, again, over a period of 1 week. And during the 12 weeks following completion of the surgeries, the nephrectomized mice, which are shown in red, were assessed for key parameters of kidney function, which includes elevations in urea and creatinine in serum compared to sham mice. And similar to what I showed in the SLE-induced model, histology can be performed in these mice to reveal pathologic induction of disease. So in addition to the several models that I described today, we offer many other disease models, including EAE, which involves induction with MOG emulsion, and PTX, atopic dermatitis, psoriasis, and DTH models of skin inflammation, asthma induction, which involves intranasal administration of modeling reagents, as I introduced today, to induce lung inflammation, and models of inflammatory bowel disease and Crohn's disease, which involve different chemical and cellular induction strategies. We are in the process of adding more models to our website, so be sure to check our newsletters, social media, and be sure to reach out to us for questions if you're interested in a certain disease model. So one of the many advantages of working with Biocytogen is the humanized mouse models that we offer in conjunction with pharmacology services. So here is just a brief list of the humanized models that we offer that may be useful for evaluating the efficacy of your anti-human test article in our disease models. So please check out our website for the full list of animal models that may be useful for your studies. I would also like to stress that we have capabilities to perform many different types of assays and readouts desired for any given disease model. And here are just some brief examples. So to summarize, no matter your target function or disease model, we definitely have the capability to help you determine whether your test article has an impact on your disease model of interest. So with that, thank you so much for joining us today, and we look forward to supporting your upcoming studies, whether they're related to disease modeling or other types of services that we offer at Biocytogen. And again, be sure to follow our newsletters and social media for the latest, including future webinars. And with that, I'd be happy to take any questions.
Thanks, Jenna, for that great presentation. We have a few questions. So what if I need a study done in a different strain than the ones listed?
Yeah, so if somebody wants to do a study in a different strain, we can definitely perform a model build for that particular strain as well. As we have already developed the capabilities of disease modeling, we can do it in any mouse type, including wild type, and any of the humanized mouse models that we offer. So we can definitely discuss more details regarding that. Please feel free to reach out to us, and then we can get back to you regarding all the information and discuss more from there.
Okay, great. Another question, so for experimental models such as OVX with the longer time window to induction, how would one decide when to treat with the test article?
That's maybe I can make some comments on this question. So definitely we will have a very clear time course for the pathological change of this disease model. So if you want to do prevention treatment, definitely we can treat this animal model in the earlier any time point or any stage of disease progression. But if you want to do therapeutic treatment, so we can identify, use the all microCT to identify some you can see some bone density change, and you can start treatment in this stage with some pathological change. So this depends on your study design.
Right. Thanks, Luke. A next question, are the humanized mice global or organ specific?
Yeah, that's a great question. So our humanized mice are global, and they're typically in situ, such that the human gene or part of the human gene is replacing its murine counterpart, so as not to affect the expression level or function.
But if
yeah,
you
sorry.
really want to, I'm
Go
sorry.
on.
Okay, if you really want some tissue specific humanization, we do have some conditional transgenic mice model can be available. So this customized model we can develop it. We have very strong gene editing team. We could work for the animal model. So you can definitely discuss with our PG team. We can help you.
Yeah, that's a great point.
Yeah, so next question, are there kidney injury models with or without diabetes with demonstrated accumulation of humic toxins?
We do have a bunch of, I'm sorry, several kidney disease model, like a chronic kidney fibrosis models. Also, we have a very acute like kidney injury models available. That really depends what you need. We have some animal model available. If you have a specific interest in this model development, we can also discuss.
Okay, great. Seems like that's all the questions we have right now. I wasn't sure if any of our other panelists wanted to add in terms of what it's like to work with Biocytogen in terms of disease modeling, whether it's any of the ones that Jenna mentioned today or some of our other models. We also have a whole list of metabolic ones too, if y'all wanted to add anything in regards to that.
Jenna, you want to make some comment? Certainly, we have a bunch of inflammatory and all autoimmune disease model available. That's to meet a very popular needs for the current market, and and there was also have some metabolic disease model like a NASH model or some other metabolic disease model available. So you can check our website, or if you need more information, definitely you can contact our BD team.
Yeah, and if you don't see the model on the website, we may be in the process of developing it. So it definitely doesn't hurt to reach out to us to see if, we have the model in development.
And I would just like to add that we have a very extensive disease modeling capability, as well as a very strong team of gene editing experts. So if you are interested in any new disease models and any genetically modified models that could be used for disease modeling, we'll be definitely happy to help.
Okay, sounds great. Yeah, and I just would like to reiterate and that you can contact us via email, phone, or the contact us page on our website to discuss any of our disease models or pharmacology or gene editing services. And we would love to partner with y'all. Actually, we have another question real quick. You showed micro CT images of the bones. I wonder if you are also doing micro CT images of brain tumors or bone tumors. If so, what is the imaging capacity?
Yes, we do have the micro CT capability that's in our China side. So we can do brain tumor imaging. Also, we can definitely do some bone tumor imaging. So we do have some data, but if you need more detailed information, we can provide to you.
Just in those lines, just to add on, we have labs both in Boston and at our China site. So if you're interested in any disease models, we can work out details and the location depending on your needs.
Yes, both very good points. Thank you so much for bringing that up. So if there are no other questions, but if something comes up later, please feel free to reach out to us and we'll be happy to answer anything you may have. And thank you all so much for joining our webinar. It's been our pleasure.
Thank you so much.
Thank you.